Good evening, everybody, to the weekly Thursday University of Miami Symposium on cerebrovascular and skull-based topics. It is session 13 on August 13. Hopefully it's not a bad omen, but I am sure it's not. I'm Jacques Morcos, professor and co-chair of the Department of Neurosurgery, director of vascular and skull-based surgery. Co-directors of this course has been and are Carolina Benjamin, assistant professor specializing in brain tumor and skull-based surgery, director of our cadaveric canes lab. Michael Ivan, assistant professor, director of research, Brain Tumor Initiative, specializing in brain tumor, skull-base, and epilepsy surgery, as well as my two endovascular, open vascular partners, Bobby Stark, assistant professor, co-director of endovascular neurosurgery and director of endovascular research, as well as Eric Peterson, associate professor, director of endovascular, University of Miami. This is beautiful Miami. These are our two main centers, UMH, University of Miami Hospital, Jackson Memorial Hospital. These symposia have been quite popular in COVID era. This is the link, as you probably know, how to reach to register. This is the list of sessions we've had over the last several weeks now, and we are now down to here, and more sessions are in the works. Housekeeping instructions. Please, audience members, use the Q&A box to send your questions. We will address them at the end of the presentations. We are not offering CMEs. If you like these sessions, please share this information on your social media. I don't think it'll be a problem today, but our speakers will speak for 25 minutes each. If I think they need a reminder that we're nearing the 25 minutes, I will let them know. Very importantly, and I do really mean this, I am open to suggestions as to what topics in cerebrovascular and skull-base you, the audience, would like to hear us present, and or what speakers you'd like us to invite. And please feel free to email me. You can see my email there, or I'm on Twitter also, or perhaps tonight in the Q&A box, you can let us know. Next week, we have a fantastic panel on dural AV fistula. Luca Regli, Rethinking the Concepts and Adapting the Classification. Greg Zipfel, Rethinking the Natural History and Adapting the Management, with wonderful panelists Rose Du, Alfredo Pedrosa, Henry Wu, Pascal Jabour. In addition to the Thursday symposia, Mike Ivan, my partner, has been doing a very successful Wednesday symposia series as well. And next, it's a Miami Global Brain Tumor Symposium. Next week is Charlie Tio, who will talk about keyhole surgery for gliomas. Again, every week I say it with great pleasure. Many, many thanks for the team behind the scenes who is making this possible. Ingrid, Roberto, Christina, and Ignacio, who is running this webinar tonight, as he does every week. You can connect with us, as I said, through the link at the top, Twitter, emails, Instagram, and so forth. If you want to know more activities we're doing, and particularly if you want to watch these recorded sessions, we have a bunch of them now already on our YouTube channel. The world is going through very challenging times. 2020, as you know, has not been a very good year and is still not a very good year for the US, for Lebanon, for the world, and so forth. It's probably why we're here virtually. If I could say something really a little bit off topic, I'd like to encourage all of us. We all have very good stories to tell, very good positive stories to tell. I encourage you all to say them, to try to drown all the negativity that is surrounding us in our social turmoil. I put my 2 cents together in a publication last week in JNS talking about the struggle that we are having here in the United States, and each one of us has a similar story to tell. And I love this quote by George W. Bush: immigration is not just a link to America's past, it's also a bridge to America's future, which will help me go to the next slide. And when I looked at this, I say, you know, these are some of the top people in the field, and look at it. They're, of course, we and they are all Americans, but of course, everybody has roots from different places. So it's a great pleasure to introduce them to you today. Bernard Bendock, roots in Lebanon, professor and chair of neurosurgery, Mayo Clinic, Phoenix, Arizona, has been doing a fantastic job heading that program over there. Adnan Siddiqui, professor of neurosurgery and radiology, University of Buffalo, New York, since 2007. He's been there, originally from Pakistan. Ali, Muhammad Ali Aziz Sultan, who used to be my resident many moons ago, and is now associate professor of neurosurgery at the Brigham, at Harvard in Boston, left us to my chagrin many years ago, originally from Afghanistan. And if I have an interesting story to tell, as I published, Ali has a 10 times more interesting story to tell, and I'm encouraging him to put it in writing, and it will have an outlet somewhere. And last but not least, Gavin Britz, professor and chair of neurosurgery at Methodist in Houston, originally from South Africa. And again, it's wonderful to have those 4 duly trained endovascular, open vascular experts with us today. Now on to the 2 speakers of the evening. First, Robert Harbaugh, Senior Vice President, Penn State Health, Distinguished Professor and Chair of Neurosurgery, Professor, Department of Engineering Science and Mechanics at Penn State. Bob did his undergrad not in Lebanon, even though I would have wished for him to have done it in Lebanon, which is where I'm from originally, but Lebanon Valley College, MD, Penn State University Medical School, residency Dartmouth. He's chair at Penn State since 2003, and I think he is the only chair that kind of came back to his old school. He is professor of engineering science and mechanics. A lot of his other work, besides what he's going to talk about tonight, relates to a complex understanding of, for example, aneurysm geometry, hemodynamics, and you can see where he gets his expertise from. He has had the highest award that his school can give him, which is Distinguished Professor and Alumni Fellow. He is Senior VP there since 2018, extensive publications, books, papers, abstracts, symposia. Amazingly has had continuous funding from various sources, including NIH, since 1985. And probably the easiest thing to do with Bob is to tell you which societies he has not been president of. But in any case, he's been in organized neurosurgery, past AANS president, Senior Society, ABNS, NeuroPoint Alliance, absolutely a powerful moving force in organized neurosurgery. And we all actually owe him an immense debt of gratitude for the time, the effort, and actually the intelligence with which he has shaped the field of neurosurgery and continues to do it. Next is John Wilson, David L. and Sally Kelly, Professor and Vice Chair of Neurosurgery, Co-Director of Neuroscience Service Line, Wake Forest University School of Medicine. John, who is, by the way, an accomplished fisherman, and I'm always jealous of all the trips he's been taking for the last 30 years with good friends of mine as well, and he goes to all the fantastic places. He grew up in Sharon, small city, Sharon, Pennsylvania. He did a combined program in 5 years, undergrad, Penn State, MD at Jefferson. So if there are any deficiencies in his knowledge, John, we will blame it on your very brief 5-year, much shorter than the rest of us, experience. He was a general surgical residency for about 3 years at Allegheny General Hospital, did neurosurgical residency at NYU, then finished at Tufts, where he's been immensely influenced by the gentleman whose picture you see, Bill Schuchart, who was a phenomenal surgeon, incredible attention to technical detail and good attention to tissue handling. John did a fellowship originally in complex cervical spine, which explains why he keeps his interest and has an active spine practice in addition to his fantastic cerebrovascular practice. He started practicing at Allegheny General Hospital, and then Wake Forest recruited him in '93 and has been a cerebrovascular and a spine surgeon ever since. John has equally served organized neurosurgery in a fantastic way. He's, of course, our current AANS president, has been president of the Southern, of the Sun, has chaired the CV section, and has done a fantastic job in the very difficult job of running the Washington Committee, AANS, CNS, Washington Committee. But of course, these two gentlemen are fantastic experts in cerebrovascular, and particularly they have had an interest in carotid surgery, carotid trials, and so forth, which is why they are here today. So I will stop speaking, and I'm going to invite Bob to start to unmute his phone, share his slides, and start his presentation.
Can you see my presentation?
We see you. No. Yes, now we see it, Bob. If you can play it in the normal mode.
Is that okay?
Perfect. Thank you.
Okay, so first, thank you very much for the opportunity to participate in this shock and for that very, very kind introduction. So much appreciated. And I think this is a great series that you've developed, and you know, this is, I'm afraid, maybe the new normal, but congratulations on doing this. What I wanted to talk to you about tonight is management of carotid stenosis, and look at it from various angles. You know, the carotid disease has been studied with randomized trials, I think more than anything else in neurosurgery. So we do have RCT data to review. There are also a lot of registry studies out there on the management of carotid disease, and I think registries are an important way of adding to our knowledge. And then finally, my personal experience. You know, there is going to be a comparison of open versus endovascular treatment of carotid disease, but I think the key is, you know, really complete institutions have both options. Sometimes one's better, sometimes another's better, and it's important to keep that in mind. I don't see angioplasty and stenting and endarterectomy as competing, but rather as complementary approaches to the management of carotid artery stenosis. Disclosures shows I'm adequately bought and paid for. There's no conflict of interest in regard to the topic to be presented tonight. So the overview, we are going to look at evaluating endarterectomy versus angioplasty and stenting through both randomized trials and registry studies. I think another really important issue, probably more important than endarterectomy versus angioplasty and stenting, is invasive treatment versus medical management alone. Do we need to do invasive treatment at all? And we're going to talk a bit about Crest II, and then finally sort of finish up with, you know, my personal experience in managing a lot of patients with carotid artery stenosis. So let's start with Crest. I mean, this audience understands Crest. You know, it was a randomized controlled trial comparing endarterectomy versus angioplasty and stenting, and it was for both symptomatic and asymptomatic patients. The procedural composite endpoint was stroke, MI, and death. They also looked at long-term endpoints of ipsilateral stroke up to 4 years. And as this was reported, what you can see is that if you look at the procedural composite, there's really no statistically significant difference between angioplasty and stenting and endarterectomy. that composite endpoint of stroke, MI, and death, 5.2% in angioplasty and stenting, 4.5% in endarterectomy. P-value there is 0.38. Similarly, at 4 years, 7.2% ipsilateral stroke in angioplasty and stenting, 6.8 endarterectomy. No significant difference if you look at that composite endpoint. There was an interaction effect that suggested that older patients may do better with open surgery and younger patients do better with endovascular treatment. But the report was that these are equivalent procedures. I would quibble with that. I think if you really look at the various endpoints that were evaluated, not the composite, what you see is that in the angioplasty and stenting group, the MI rate was considerably less. And that was, if you look at the areas where one of these two procedures was superior to the other, angioplasty and stenting was superior to endarterectomy if you looked at myocardial infarction in all patients. Also, of course, cranial nerve injury. You don't have the cranial nerve injuries with the endovascular treatment. Endarterectomy, however, was statistically significantly superior to angioplasty and stenting in procedural stroke in all patients, stroke in symptomatic patients, stroke and death in all patients, stroke and death in symptomatic patients, 4-year stroke rate in all patients, 4-year stroke and death rate in all patients, same in symptomatic patients, and perhaps most importantly, significantly better in overall quality of life. There was no significant difference between the two in the composite endpoint, which was what was reported. There was also no significant difference in myocardial infarction if you looked at only symptomatic patients. So, honestly, I would look at this data and say, this is pretty much an endorsement for endarterectomy. But if you look at that composite endpoint, you couldn't see the significant differences that existed in the various treatment options. There was a follow-up, 10-year follow-up. And again, if you look at the composite endpoint, what you see is there's no significant difference out to 10 years. 10-year stroke and death, these curves are remarkably similar. So I think both endarterectomy and angioplasty and stenting, achieve what you want to do. There's just a higher perioperative risk with angioplasty and stenting, and then the two procedures seem to be parallel from there on. Same thing if you just look at stroke. So what I think this tells you is that it's that early perioperative period that differentiates endarterectomy and angioplasty and stenting, and from there on the curves parallel each other. There are a number of other randomized trials that I'll go over very quickly. The International Carotid Stenting Study was a multi-center randomized trial. Again, the endpoint of stroke, death, and MI. 1,713 patients. In this study, an 8.5% angioplasty and stenting composite endpoint versus 5.2% endarterectomy, and that was statistically significant in favor of endarterectomy. Interestingly, they did not find the difference in MIs. There are 3 fatal MIs with CAS, 4 non-fatal MIs with endarterectomy, not different. One really interesting piece of this, I thought, was a sub-study of ICSS where they looked at MRI following either angioplasty and stenting or endarterectomy. Found that after angioplasty and stenting, there was a 50% incidence of new ischemic lesions on the MRI. There was 17% after endarterectomy. And the angioplasty and stenting patients were more likely to have persisting lesions at 1 month. Moving on to some registry data, I thought this was an important study that came out in the European Journal of Vascular and Endovascular Surgery in 2015. And what they did is they looked at a large number of reported registries in both asymptomatic and symptomatic patients. And the size of these little balls here shows the number of patients in the study. Red are angioplasty and stenting patients, blue are endarterectomy patients. And I think if you look at this, there does seem to be a separation, that if you look at death and stroke rates, they are higher for both asymptomatic and symptomatic patients with angioplasty and stenting than with endarterectomy. These lines are the point at which you may have value from your procedure. So in asymptomatic patients, going all the way back to the ACAS study, the thought was if you could do your procedure with less than 3% complications, that you would have a benefit. I think that that's probably too high. And I would suggest that if you want to have a benefit for asymptomatic patients now, because the medical management has improved so much, you probably need to be able to do your procedure with a less than 1% complication rate. So those are the two lines. For symptomatic patients, 6% was the NASIT suggestion. I think you probably need to do it with 3% today. And I would suggest that for asymptomatic patients, I'm not sure any of these registries would actually show a benefit over medical management alone. For the symptomatic patients, I think there are quite a few of the carotid registries where that would be the case, but not with the angioplasty and stenting registry data. This is, I think, an important study that didn't get as much attention as I suspected it would. It came out in JAMA 2017. Tom Brott is the senior author. And basically what it shows is if you look at a large number of endarterectomy and angioplasty and stenting patients in the U.S. Medicare database, what you see is very interesting. They looked at this over a long period of time. And so if you look at the ischemic stroke or death, ischemic stroke, MI or death, all-cause death, and look at 1999 to 2000, you see that for endarterectomy, those numbers have improved, and they've steadily improved over time. I mean, one of the criticisms of endarterectomy is it's old technology. It's something you've been doing forever, and the new way to do this is endovascularly. So that technology is, constantly improving, and we're going to do better and better. But endarterectomy can't. And actually, what the data shows exactly the opposite. That the endarterectomy complication rates have steadily gone down. I suspect because of perioperative management choices. Whereas angioplasty and stenting, in a very large number of patients, you see going back to 1999 and all the way up to 2014, it really hasn't changed. And I think that's a surprising result, but probably a true result, at least as for the way that endarterectomy and angioplasty and stenting are really done in the United States, not how they are done in the very best of hands for either surgery or endovascular treatment. So another topic, and again, I think this is one that may be more important than how we do our invasive treatment, and that is, should we be doing invasive treatment at all, or should we go with medical management? I was part of the NASIT study, the original study, and what it showed was that there was a marked benefit of endarterectomy for stroke prevention in symptomatic patients, greater than 70% stenosis, and a moderate benefit in patients with 50 to 70% stenosis. The ACAS study showed a modest benefit of endarterectomy for stroke prevention in asymptomatic patients with greater than 60% stenosis. And it was reported that there's no benefit of endarterectomy for patients with less than 50% stenosis. Now, that's not true, but that's what was reported. If you really look at the data, here's what it shows. And it's so what we're looking at here is stroke prevention by endarterectomy at 2 years. You if you look at the NASCET data, in the very high-grade stenosis group, 17% absolute risk reduction if you had an endarterectomy, 67% relative risk reduction. You needed to do 6 operations to prevent 1 stroke at 2 years. And of course, the p-value is ridiculous. If you look in the 50 to 69% stenosis group, an absolute risk reduction of 6.5%, relative risk 29%. Now you need to do 15 operations to prevent 1 stroke at 2 years. And because we have a magic number of a p-value less than 0.05, that's significant. So it says, okay, we can do this. It's reported that there was no benefit in less than 50%. But in fact, if you look at the data, the absolute risk reduction in the 30 to 49% group, 3.8%, 20% relative risk reduction. You needed to do 26 endarterectomies in that group to prevent 1 stroke at 2 years. But because we, by convention, say a p-value has to be less than 0.05, this was not statistically significant. However, what that p-value means is that the chance that this amount of difference occurred, by dumb luck, by chance alone, is 16%. But to say there's no evidence that it helps is not true. Now compare this to the ACAS data. In ACAS, the absolute risk reduction in patients with greater than 60% asymptomatic stenosis was 1.5%, or less than half of the absolute risk reduction in this group. There was a 30% relative risk reduction, but you needed to do 67 operations to prevent 1 stroke at 2 years. But because of the way they tortured the data, they got the p-value to come out less than 0.05. So for many years, we are saying, the data say that the benefit here is twice as much as here, but because of this one number, it's okay to do these asymptomatic patients, and it's not okay to do these symptomatic patients. That's lying with statistics, and I think we're past that now. One of the things that's really struck me is when I was involved with those earlier studies, best medical management was usually an aspirin. And the medical management of asymptomatic carotid stenosis, aggressive use of statins, antiplatelet agents, much tighter blood pressure control. I mean, the medical management is just much different now than it was when those studies were done. And if you look at annual stroke rates in medically managed patients with asymptomatic carotid stenosis, they're under 1% a year. I mean, they're so low, it's going to be hard for any invasive therapy to show a benefit in regard to stroke prevention. There are almost certainly subsets of patients at higher stroke risk, and people have looked at things like transcranial Doppler, detection of clinically silent emboli, rate of progression of stenosis, MR evidence of clinically silent infarctions, the total atherosclerotic plaque burden, plaque characteristics on various kinds of imaging studies, and other criteria in trying to say, well, of all of this universe of asymptomatic stenosis, is there a subgroup that really benefits from intervention? And there may be, but it hasn't been clearly defined. So it brings us to Crest II. Crest II, conducted with patients who have greater than 70% asymptomatic stenosis, is to assess the treatment differences between medical management versus endarterectomy and medical management versus angioplasty and stenting. I think the most interesting piece of this study is the plan to assess differences in cognitive function at 4 years of follow-up. They're also going to, of course, assess differences in major stroke events at 4 years. And this study has been designed to assess the effects of age, sex, severity of carotid stenosis, risk factor levels, duration of the asymptomatic period on the primary outcomes measures. We are part of Crest II. I think it's going to give us some very interesting information, and some information that just is really not available right now, particularly on the cognitive function. If indeed we can show that revascularization of a highly stenotic internal carotid artery has a protective effect on cognitive function at 4 years, that just completely changes the landscape, because now our indications for surgery are not going to be stroke prevention, they're going to be prevention of dementia. And that, I think, is a very exciting possibility. I remain very skeptical that we're going to be able to show a benefit of either endarterectomy or angioplasty and stenting compared to medical management alone in regard to stroke prevention, but time will tell. Personal experience, I've done more than 2,000 endarterectomies in my lifetime. And we started collecting prospective data on this procedure in July of 1990, and before most people, had computerized databases, and it's been a very good in regards to publications, but even more important in looking at how some changes in the management seem to result in a change in the outcomes. All of the outcomes in this database were determined by an evaluator other than the operating surgeon. We had 100% 6-week follow-up, most of that with patients coming back to clinic, but if for any reason they couldn't come back to clinic, we had a nurse practitioner contact them via telephone to do the follow-up that way. So, not a randomized study, but a very good registry. So when I look at my data, 99+% of the patients were done with a regional anesthetic. In the original Crest study, 90% were done with general anesthesia. I am convinced that the regional anesthesia does reduce the myocardial infarction rate based on my data. And so I think that, how you do the procedure, whether it's how you do the angioplasty and stenting or how you do the endarterectomy, is clearly going to have an effect on the outcomes. I've been using dual antiplatelet agents for 2 decades preoperatively. Everybody gets aspirin and Plavix before surgery, and it's maintained for 6 weeks afterward. Not even mentioned in the endarterectomies in Crest, although it's standard treatment to use dual antiplatelet agents for angioplasty and stenting. What I saw when I started using dual antiplatelet agents, I started doing these operations with a general anesthesia, and when I switched to regional anesthesia, it really reduced the complication rate as far as cardiopulmonary complications. It reduced the length of stay. It reduced urinary retention. There were a lot of positives for switching from general to regional, but it did not change the stroke rate at all. And it did not change the stroke and death rate at all. But when I switched to using dual antiplatelets, both the MI rate and the stroke rate dropped by about 50%. Can I prove that's cause and effect? Without the control group, you can't. But I think there is at least reasonable evidence that dual antiplatelet agents make sense in the perioperative period. And we did not see an increase in our hematomas. I used to not reverse the heparin when I switched to dual antiplatelet agents. I did reverse the heparin at the end of the procedure, and there was absolutely no change in the rate of neck hematoma. So this is just looking at the last 500 patients that were done by the end of June 2014. 499 were done using aspirin and Plavix. 497 were done with regional anesthesia. The 3 patients who were not done with regional anesthesia, one was a patient who was deaf. And I think it's really important with regional anesthesia to be able to converse with the patient. One spoke no English, and so again, that was done under regional or under general anesthesia. And there was only one patient who absolutely refused to have the operation done awake. And of course, it was this, big macho guy, with a lot of gold chains and stuff. And he said, no, he absolutely wasn't going to be awake for his surgery. But you can do regional anesthesia in almost every patient. 89% of these patients were in symptomatic disease. I used to do a lot more asymptomatic stenosis, but as I said, I've become convinced that asymptomatic stenosis is probably not an indication for intervention. There were 3 perioperative strokes in this group, 3 perioperative MIs in this group. There were 2 neck hematomas, 1 cranial nerve palsy that persisted at 6 weeks, and 1 death. And that was actually an aortic dissection following endovascular retrieval of an embolus that occurred at the time of surgery. So the overall outcome with this group was really excellent, and I think it's the kind of thing that you can achieve with open surgical treatment. So if the question is endarterectomy versus angioplasty and stenting, I think overall, if either are options, endarterectomy, is probably still has a benefit in regard to the perioperative complications. Is that the case at every center? Probably not. I'm sure there are plenty of places where the endovascular treatment, because of the people who are doing it, is better than the open surgical treatment because of the people who are doing it. And I think it's really good to have both options. I know at Penn State we have 5 vascular neurosurgeons, 4 of whom are dual trained. I'm the dinosaur. I'm not. From the standpoint of aneurysm disease, I mean, we're well over 90% of the aneurysms that are now being done endovascularly. But for carotid disease, the endarterectomy remains the default position. If for some reason it's not a good patient for endarterectomy, it's really nice to have very skilled endovascular neurosurgeons who can do the endovascular procedures. If the question is endarterectomy versus medical management in asymptomatic patients, I think the answer is we don't know. My suspicion is no intervention is going to beat medical management alone for stroke prevention in the asymptomatic patients, but Crest should help sort that out. The effects of asymptomatic carotid stenosis and revascularization on cognitive function is where I think the most intriguing question is right now. And I hope Crest gives us some idea if we may actually help prevent dementing illness by revascularizing the carotids in these asymptomatic patients. So my conclusions, looking at the randomized trial data, the registry data, and my personal experience, that endarterectomy remains the best option overall to remove the source of the artery-to-artery emboli that are the cause of stroke in symptomatic carotid artery stenosis. I think that based on both the RCT and registry data, endarterectomy is superior to angioplasty and stenting in those patients. But once again, that's not the case at every institution, and having both options, I think, is essential. And then whether any invasive therapy for asymptomatic carotid artery stenosis is better than medical management alone is under investigation, but I am a skeptic. So thank you for your attention, and once again, I appreciate the opportunity to present. Thank you, Jacques.
Thanks so much, Bob, for this overall look at it. I mean, very few people understand the topic as deeply as you do, and I'm sure the participants appreciated this quick overview of the main topics. So I'll invite John to unmute his microphone and share his slides and tell us maybe perhaps more the technical aspects of the surgery, how he does it. And for the participants, go ahead, please, as you think of questions, submit them to the Q&A box so we can address them at the end. Thanks, John.
Okay, thank you, Jacques. Thanks for inviting me to participate. This is terrific. Bob Harbaugh is always a a hard act to follow. Bob, that was great. Thanks for sharing your experience and all the data on the trials. I'll try to share a little bit about our experience here at Wake Forest, which I think is fairly similar to that at Penn State. Obviously, Bob's series is second to none. That is an amazing body of work that he has accomplished with a prospective analysis of it to boot. So that is really terrific. But I'll talk a little bit about how we do things here at Wake Forest and talk about some of our results and how to try to avoid some complications.
John, click on the slide and then you can advance.
Okay, thanks. Oh, perfect. So again, I have nothing, no relevant relationships with commercial interests to disclose. No discussion of non-FDA approved or off-label use of drugs or devices will occur in this talk. So the Wake Forest endarterectomy protocol is again using a regional anesthetic. We use a superficial cervical plexus block along the sternocleidomastoid. My experience before coming to Wake Forest was similar to Bob's, where we're doing all my endarterectomies under general anesthesia with full montage EEG monitoring. Came here and talked to an older neuro anesthesiologist and said, you know, you ought to really look into this, doing some of these awake. He said patients just seem to do great. And, you know, once I started seeing, you know, really just how well the patients did with an awake endarterectomy, how quickly they got out of the hospital, how much better they felt post-operatively, it really never looked back. It allows for careful neurologic monitoring, obviously, because you can basically are able to continuously perform a neurologic exam, which is about the most sensitive means of monitoring. We do a primary closure of the arteriotomy, except in the case of a restenosis, which we rarely operate on anymore, or a native vessel that is less than 3 millimeters in size. We monitor all the patients in the ICU post-operatively. They may be there from between 8 to 12 hours post-op, and then the 95% of them are discharged the following morning. So in terms of looking at the regional versus general anesthesia, there's really been a lot of papers written about this, a lot of research done into it. There was, in fact, a landmark paper published in Lancet that was the results of a randomized trial looking at general anesthesia versus local anesthesia for carotid surgery. Over 3,500 patients were enrolled, and again, their primary outcome measures was a composite endpoint of stroke, MI, or death within 30 days. And on the basis of this trial, they really could find no conclusive data supporting either method of anesthesia. But despite that, there were continued to be numerous anecdotal reports and case series that seemed to indicate a benefit to regional anesthesia. A more recent publication, and I think one of the most informative publications on the subject, was published in Stroke last December, looking at associations of perioperative variables with a 30-day risk of stroke or death in carotid endarterectomy in symptomatic patients. And this came from the Carotid Stenosis Trialist Collaboration, where they pooled the data from these 5 trials. And as a result of that, over 4,000 patients were analyzed. You can see that the majority of them had general anesthesia, but there were over 1,300 that had undergone local anesthesia. Primary outcome in this analysis was any stroke and 30-day mortality. And what they found was that there was a local anesthesia was associated with a lower primary outcome rate with an adjusted relative risk of 0.7. And you can see the confidence interval there. So again, this was sort of the first study to show a clear-cut and statistically significant benefit to local anesthesia over general anesthesia in terms of outcomes. Now, one of the benefits of a local anesthetic is the ability to have a careful neurologic exam, which allows you to detect early on any changes, potentially perfusion-related changes in the patient's neurologic exam. And this allows us to perform selective shunting on our patients. We only shunt those patients who have a change in mental status or develop a focal neurologic deficit that is refractory to elevations in their blood pressure and improved perfusion. When we do a shunt, we use the Pruitt and Harbaugh shunt, which you see here. It has the soft elastic catheter with balloons that are captured with a vessel loop that holds it in place. It can be back bled and then reperfused in the case where the patient develops neurologic symptoms. So again, the question of selective versus empiric shunting is one that has been talked about a lot. And selective shunting does require some sort of careful assessment and in order to determine which patients will require reperfusion during the procedure. Again, there hasn't been conclusive data to support either method, but looking back at the trial that was published in Stroke, this is a forest plot looking at the results from that previous trial I'd mentioned. And one of the key points you can see here is that there was a statistically significantly worse outcome rate in those patients who were shunted as opposed to those who were not shunted. So I do think that there's some good evidence to support the use of selective shunting. And awake endarterectomy does give you, I think, in my opinion, the most sensitive means of determining which patient ought to have an intraoperative shunt. So in terms of the preoperative evaluation, years ago we had done cerebral angiography on virtually all of our patients, but it is an invasive procedure that carries some inherent risk. We have pretty much uniformly switched to CT angiography. CT angiography gives you the same sort of roadmap and the same sort of anatomic correlation that I find very useful in the procedure, yet does it in a non-invasive and low-risk way. You really see the morphology of the plaque very well. You can see the calcification in it. You can localize the location of the disease very carefully in the neck, which has afforded us the ability to try to improve the cosmesis of the procedure by doing a transverse, fairly small incision. This is the positioning of the patient. We create sort of a tunnel here so that the anesthesiologist will have direct access to the patient's face, be able to talk to them, and perform the neurologic exam throughout the procedure. The local anesthetic is just a superficial block along the sternocleidomastoid that anesthetizes the superficial plexus of nerves. You can see these nerves run right subcutaneously over top of the sternocleidomastoid muscle. Those cutaneous nerves are basically cut once you do your dissection along the sternocleidomastoid muscle, which accounts for the diminished sensation on the superior aspect of the incision that tends to last for between 6 to 9 months on patients after the procedure. But we find that very effective, and then we supplement by injection in the carotid sheath once we're directly down visualizing the carotid artery, which helps avoid hematomas or direct injection into the vessel. You can see that we do a transverse incision here. It generally is in the range of around a 6 to 7 millimeter length or centimeter length incision that is necessary for the procedure. Sometimes with high bifurcations that has to be extended somewhat. This slide is how do I go backwards, Jacques? Okay. This slide is a demonstration of the initial exposure. This is the common facial vein. This is the sternocleidomastoid artery. This is a fairly robust appearance of this artery, but it is a commonplace artery that runs and can tether down the hypoglossal nerve. This artery can be uniformly sacrificed and it runs over to the muscle or a chain of lymph nodes. And once you do, you're able to mobilize the hypoglossal nerve much more effectively. To me, the key to dealing with a high bifurcation is the dissection between the posterior belly of the digastric muscle and the sternocleidomastoid. working in this angle and getting that all the way to the skull base really can give you access to the distal internal carotid virtually all the way to the skull base. So, you know, we talk about hostile necks and that being a reason for carotid stenting. A high bifurcation in our experience is virtually never really a contraindication to carotid endarterectomy because you really can expose the carotid virtually to the skull base. So it's only if that bifurcation is so high that it's going to be difficult to get distal control that we would consider converting to a carotid stent. We have some specialized retractors. This is called a Haney retractor that seem to assist with the exposure of those high bifurcations as well. It can retract the posterior belly, the digastric muscle, out of the way very carefully. You do have to be somewhat cautious because if you pull this up underneath the angle of the mandible, you can get a marginal mandibular paresis of the facial nerve. When you see those there almost uniformly get better on their own without any intervention, but it is bothersome to the patient for a period of time. This is once we've exposed the carotid, I generally expose, particularly in symptomatic patients, expose just the internal and the common carotid without disturbing the carotid bifurcation or the plaque much at all. We have our umbilical tapes in place that would allow us to capture the Pruitt-Inhara shunt if necessary. And then the first thing we do is heparinize the patient and place the distal clip on prior to dissecting out the bifurcation. This we found can, we have at times monitor transcranial Dopplers on these patients while we're doing the procedure and have found that the number of hits distally by doing this maneuver prior to manipulation of the carotid bifurcation has been very effective in embolizing the number of hits that we would see on a transcranial Doppler. So we think it's potentially beneficial in terms of minimizing the risk of perioperative complications. But once we place that, we're monitoring the patient, so we will know very quickly if they're developing symptoms, and it's at that point that we dissect out the bifurcation and place the vessel loop on the external carotid and its branches. Okay, let's. So the endarterectomy itself, I prefer an extra plaque dissection, which you'll see here. That has allowed us to take the plaques out on block, which has permitted us to do a lot of interesting research on the plaques. We've done some analysis of the mRNA of the endothelial cells and the cap cells within the plaque. As you can see, this plaque will go all the way down to the aorta. So at some point you have to amputate it, but it's with the direction of flow proximally, so there's no problem there. Where we spend a lot more time and attention to detail is at the distal end. And so this transition between the endarterectomy site and the normal appearing distal intima is something I really spend a lot of time on to get a nice smooth plane of transition. Virtually never place tacking sutures, have not found that necessary. You just really have to get up beyond the area of stenosis and pay a lot of attention to get a very clean transition between the endarterectomy site and the distal intima. So we do a primary closure. This is what the closure looks like. With this sort of fine suturing technique, I don't think a patch is necessary. I don't think there's anything inherently wrong with a patch. Many people do that, and it allows you to, you don't have to be as particular about the suture line, but we have not found particular problems with restenosis despite not using a patch. So in terms of our results, looked at this probably 10 years ago when we presented at the International Stroke Conference. We were interested in looking at our outcomes relative to components of the Crest composite endpoint and outcomes in patients with contralateral carotid occlusion in particular. We had not seemed to find the increased risk that other centers had demonstrated with contralateral carotid occlusion, so we're specifically interested in looking at that. We did a retrospective analysis of 535 consecutive procedures of patients that were undergoing carotid endarterectomy, including those with contralateral carotid occlusion. We looked at the complication rates and the impact of shunting on the overall outcome and the rate of shunting relative to whether or not they had contralateral carotid stenosis or occlusion, excuse me. So the demographics of our patients were, as you see here, pretty typical, and there was no difference in these between those patients with contralateral carotid occlusion and those without. Group 1 were the contralateral carotid occlusion patients. There were 51 cases. 58% of those were asymptomatic. In group 2, there was no contralateral carotid occlusion, 484 cases, 50% of those asymptomatic. We have also probably do far less asymptomatic patients nowadays than previously and are participating in Crest II. I really think Crest II is going to answer an important question in regards to those asymptomatic patients, and we try to enroll all of our asymptomatic patients into Crest II. So in terms of the anesthesia, you can see that in the group 1, 8 of 51 cases had a general anesthesia. The thing about that is that 6 of those were conversions from regional anesthesia to general anesthesia. And there's a subset of patients with contralateral carotid occlusion that when you cross-clamp the internal carotid, they immediately develop profound neurologic deficit. In my hands, where I very infrequently do an indwelling shunt, it takes a good 5 or 6 minutes for me to get a shunt in and get it flowing, particularly in a point where the artery has not even been opened yet. May take longer than that. So in those patients who developed the very profound symptoms, our method had been to remove the internal clamp, reestablish flow, get them back to their neurologic baseline. And then we would, knowing that we were going to put a shunt in those patients, we would put them under general anesthesia so that we could use neuroprotection during that period of time, that they would be ischemic until we got the shunt in place. And that was 6 of the 8 patients that had general anesthesia in this smaller group 1 series. In group 2 of the 480 patients, 10 of those cases had general, and these were the indications that we saw for general anesthesia, sort of the same things that Bob had mentioned. Very, very few, and it's become even much less in our more recent patients. So it was interesting that we found that still the vast majority of patients, even with a contralateral carotid occlusion, tolerated cross-clamp without neurologic symptoms. 77% of the patients had no problems with cross-clamping. Even greater in those with an open carotid on the contralateral side, where 97% of those tolerated cross-clamp without any development of symptoms. Our complication rate was fairly low. We had a 1% medical complication rate, perioperative stroke or death of 1.2%, permanent cranial nerve paresis in 1% overall. We had one unfortunate circumstance of a vocal cord paralysis, 1 permanent marginal mandibular, had no instances of a hypoglossal nerve palsy, relatively low incidence of wound hematoma or infection. One thing which I intended to mention, which I had not, was our antiplatelet protocol. We treat all the patients with 650 milligrams of aspirin, unless they are preoperatively on dual antiplatelets, in which case we maintain the dual antiplatelets through surgery. it was found in the NASA trial that that doses of aspirin less than 650 milligrams were one of the factors that led to an increased risk of perioperative stroke. I think the reason for this is that there is an incidence of aspirin non-response that I believe is dose dependent. And so the vast majority of people, probably over 80% of people, will respond adequately to a dose of aspirin of 81 milligrams. But in the remaining 20% who may be considered non-responders at that dose, if you increase the dose, you will significantly increase the number of responders. So that getting to a dose of 650 milligrams, you probably get in the very high 90% in terms of the percentage of patients who are responding to aspirin and having their platelet aggregation adequately blocked to prevent postoperative complications. So that has been our protocol with that, but I think the dual antiplatelets, as mentioned by Dr. Harbaugh, would be, if not more, equally, if not more effective. So what we found is that patients with contralateral carotid occlusion are much more likely to develop symptoms of cerebral ischemia that would require carotid shunting, but still the majority of them will not. Endarterectomy under regional anesthesia with selective shunting can be accomplished with an acceptable morbidity mortality. Crest demonstrated equivalency of endarterectomy and carotid stenting, but as Bob pointed out in his talk, that may have had more to do with the selection of the composite endpoint than the specific outcomes, particularly as it relates to stroke. So when you look at those values, you can see here that there are very significant differences in the components of the composite endpoint. So stroke was significantly favored for endarterectomy versus stenting, whereas MI was significantly favored for stenting as opposed to endarterectomy. Again, this may have had something to do with the selection of anesthetic techniques, as 90% of the endarterectomies in Crest were done under general anesthesia, whereas none of the stent procedures were done under general anesthesia. Again, it held true for peri-procedure major ipsilateral stroke, 4-year major ipsilateral stroke. You can see that the stroke outcome significantly favored carotid endarterectomy, whereas obviously cranial nerve palsy would significantly favor carotid stenting. So again, not too much more to say about Crest. I think Bob covered that very sufficiently. We are participating in Crest II, and we hope that it will supply some additional insight into the management of asymptomatic patients. But I do agree with Bob that I have a great deal of skepticism that any intervention is going to necessarily beat the treatment of asymptomatic carotid stenosis, particularly when you base your patient selection purely on degree of stenosis. I think ultimately we're going to become much smarter about selecting patients, and we'll identify those risk factors that put patients at higher risk, and we'll be able to more selectively intervene on the appropriate patients. So in terms of complication avoidance, preoperatively, it's all about patient selection, whether or not they have a contralateral occlusion, a hostile neck, appropriate antiplatelet medication, as we've talked about. Intraoperative, it's monitoring changes in the patient's neurologic condition, changes in mental status or focal deficit related to hyperperfusion can, in a significant percentage of patients, be reversed by blood pressure elevation. Otherwise, we would go on with shunt placement. I think careful inspection of the distal endarterectomy site and assurance of back bleeding is critical. And really, we will follow the plaque up as far as is necessary to really get to a smooth transition point, as opposed to placing tacking sutures or things such as that. In the postoperative period, ICU observation for close blood pressure monitoring is, I think, very important, and also allows for early recognition of wound complications. What we found with the patients under regional anesthesia is that the majority of them, if they have blood pressure problems, it's with reflex hypotension. And many of these patients are requiring blood pressure support in the first 8 to 12 hours post-operatively. This is a demonstration of an intraoperative shunt complication. This is a patient became profoundly weak on their contralateral side. We placed the Pruitt and Harbaugh shunt. One of the things about that shunt that you have to be very careful of is paying close attention to the balloons that are attached to the, or the syringes that are attached to the balloons that are inflated within the artery. And unfortunately, in my haste to place this, I wasn't paying close enough attention to the syringe that was placed on the 1 cc balloon in the distal end. The resident blew that up fully with about 5 cc's, really overexpanded the vessel tremendously, created this dissection and pseudoaneurysm. You can see that was successfully treated later with an indwelling stent. This is the 2-year follow-up period, and you can see they've developed a recurrent stenosis that was treated with a stent as well. That's generally, if we have recurrent stenosis, that is the way that we treat it is with endovascularly. We generally do not reoperate. It can be a good bit more difficult to reoperate. I wanted to demonstrate again a circumstance in which a patient had developed a carotid occlusion between the time of their study and when they presented for their endarterectomy. It looked like it was a fairly fresh occlusion, or relatively fresh occlusion. We tried to use a Fogarty catheter to re-establish the carotid flow. We're unsuccessful in doing that in this case, but you'll see the demonstration of that. And you'll see the demonstration again of how we do the extra plaque dissection and are able to get the plaque out on block. So here you can see it just kind of came out of the internal, the telltale sign of that organized thrombus. We have no back bleeding going on here, trying to pass Fogarty catheter up to the skull base, pass it up about 10 centimeters here to try to get into the petrous portion, blow up the balloon, and try to deliver a clot back. But if it's beyond the skull base or is more chronically occluded, trying to do more than that without having angiographic control, I think really risks developing distal embolic complications. So this was unsuccessful, ended up just oversewing the stump, and they were not able to reestablish that carotid flow there. So with, so with that, I will conclude and be happy to take any questions from the chat room.
Great. Thank you so much. And for the participants, you can see how volume and experience counts. Obviously, both John and Bob are extremely experienced, and those low morbidity numbers are very hard to replicate unless you do a fair amount of endarterectomies. So while I'll ask Bernard to load his case. While he's doing that, I'd like to squeeze in one question from the audience. Bob, I'll ask you this question by Dr. Stephen Cohn. Here is the question. Since, and Bernard, go ahead and you can share the slides. Since it is unlikely that CA or stenting for asymptomatic patients improves long-term outcome, but may be associated with more adverse effects peri-op, how can I, as a medical consultant, convince surgeons and anesthesiologists not to screen for carotid stenosis or refer patients with asymptomatic stenosis for prophylactic intervention prior to non-cardiac, non-neurologic surgery? The risk of peri-op stroke in non-cardiac surgery in a patient with no prior CVA is less than 1%, which cannot really be improved by an intervention. How would you answer his question, Bob?
Well, one, I think if you're asking how can you get people not to do it,
Right.
I have no idea. I think we generally are very poor at risk assessment, and so we look at a narrow carotid that was study obtained for whatever reason, and we go into our treatment mode and say, well, we should fix that before we do this other surgery. I completely agree with the questioner that there's no data to say that makes any sense to do that. And the only thing I hope is if indeed we have a very reliable study like Crest II that says, overall intervening for asymptomatic stenosis doesn't improve stroke outcomes, that data will then be applied to these other situations. That's my hope, but I've become somewhat cynical. It can be very hard to change treatment patterns once they become established.
Thanks. John, the other half of this question I'll pose to you also from Stephen Cohn. What is your opinion about screening for and intervening for carotid artery stenting prior to CABG? Or maybe you can answer the interplay of CABG and carotid surgery or carotid screening. What's your position on that?
Sure. So, well, I think screening in general, there's a difference between screening and needing to intervene procedurally with based on the results of the screening. And so I think screening is a very good thing because knowing that you have carotid disease and managing the risk factors and appropriately having the aggressive medical treatment that is necessary can dramatically reduce the risk of stroke. Bob was talking about non-cardiac and non-vascular procedures, and there not being any potential or any recognized benefit to prophylactic carotid endarterectomy or any kind of carotid intervention in that situation is certainly true. But the data when it comes to CABG and those coronary interventions where they're going on bypasses is somewhat different. And there may be some benefit in that circumstance. I'm not tremendously familiar with that CABG literature. I don't know if Bob has something else to say about that, but I'd be interested if he's particularly familiar with that literature in the CABG population.
Yeah, I actually wrote a paper about that many years ago, sort of mid-90s, looking at endarterectomy and CABG done, simultaneously. Do the endarterectomy and go right to the CABG, staged. Don't do the endarterectomy, and actually you can make a case for prophylactic endarterectomy at that time. But again, what's different now is the state of medical management, both perioperatively for the CABG, and as you pointed out, John, the really aggressive treatment of risk factors, and the landscape has really changed for stroke prevention from medical management alone. So I would not do that now, even though I wrote a paper 25 years ago that said that was, the right thing to do. I don't think there's a good indication for intervention in asymptomatic carotid stenosis in general, although I continue to do a very small number of very specific patients, young, rapidly progressive stenosis, someone who the neurologists have found has embolic hits on transcranial Doppler, but that's the very, very small subset of the asymptomatic stenosis. In general, I think they're not patients who need to be treated invasively.
So
Thanks,
I'll
Bob.
make one comment, Jock. So the thing, it really depends on who's treating the carotid disease. If you look at at Methodist, which is a large heart center, our cardiologists do the stenting, of both the coronaries and the carotid, so large the volume. So when those guys get evaluated, I can promise you, every patient that gets a coronary evaluation at Houston Methodist gets a carotid evaluation by the cardiologist to make sure they don't get to us. So, I mean, that's no doubt about it. Depends on the situation. I think when neurosurgeons like your program runs most of those cases, it's different. But in our center, those cardiologists are extremely aggressive.
Oh, yeah, we refer to those as drive-by stentings. And there are practitioners in our area, not in our institution, who, as far as I can tell, the indications for angioplasty and stenting are carotid in situ. I mean, if there's any possible reason to talk people into a stent, they'll get it. And you're exactly right. If they do the coronaries, well, why not throw one in the carotid as well?
Okay, Bernard, your show for now. You're muted, Bernard. You're still muted.
I see. Sorry, can you hear me now?
Yes.
Sorry about that. Dr. Marcos, I want to thank you for the honor and privilege of being part of this incredible symposium. You've set a new standards. To use your analogies, you raised a phoenix out of the COVID fires to set a new standard, educating, sharing, and inspiring. So thank you. And also want to thank Dr. Harbaugh, Dr. Wilson, incredible talks. I feel a little embarrassed to follow you, but what I brought here today is just a very simple but very interesting case. There are no tricks here. It's just it's a bit off the beaten path, a little different. I know I wouldn't have anything to add to Dr. Harbaugh and Dr. Wilson's talk from an endarterectomy or carotid, standard carotid standpoint, but this is sort of out of left field a little bit. So this is a 45-year-old gentleman, a bit obese, right-handed, referred for progressive asymptomatic bilateral ICA stenosis. He has hypertension, type 2 diabetes. He had a coronary angioplasty 2 years and stenting 2 years prior. And if I can get this to advance. So he has, bilateral carotid stenosis, looked very severe on both sides. We pinned our excellent radiologists down. They thought that the left was a little bit more stenotic. This picture actually may not show the nuances of that, but based on their axial imaging, they thought the left maybe is a little bit worse, but it was a toss-up. So perhaps anybody from the panel, Dr. Harbaugh, Dr. Wilson, what would you do in this case?
Yeah, I think this would be one of the exceptions I talked about. Very young, you don't know the rapidity of progression, but at 45, it must have progressed fairly fast to be looking like that. And the bilateral nature, I think, is concerning too. So this is one of those exceptions where I would go ahead and probably do the left carotid first, and then wait 6 weeks and do the right one.
I feel good because that's exactly what I did. We did a left endarterectomy. It went well, no problems. 6 weeks post, and my plan was to bring him back 6 to 8 weeks later and do the other side. But he comes back 6 weeks later. Unfortunately, he didn't call me when he started having symptoms, but with about 24 hours of facial droop and left hemiparesis. MRI showed, an acute MR showed a right temporal infarct, no evidence of hemorrhage, sort of a small to medium-sized infarct. MR angio, also done acutely, suggested right ICA occlusion, which I thought maybe was artifact. We admitted him to the ICU, and we got an angiogram because I was worried. We weren't sure what was going on. And the right ICA was occluded. So the opposite, the other side from the endarterectomy we had done. And our endarterectomy set looked excellent, no significant issues there. What was very interesting is he has a hypoplastic left A1, but you can see some collateral here across the midline to the right ICA, supraclavicular ICA right here. I don't know if you can see that very easily, but it's right there. And what's interesting is his external carotid on the occluded side was showing a lot of collateral to the carotid, and his the right hemisphere was filling in part from this modest PCOM. And again, here on the left, on the right here, you see the collateral across the midline. So we admitted him to ICU, and he's about maybe 24 to 36 hours out now from his symptoms. He's got a medium, and I'm sorry I don't have the MR that shows the infarct, but he has a small to medium infarct, frontal lobe infarct. Perhaps Dr. Wilson, what would you do in this case?
Sorry, before he answers, Bernard, how many days after your surgery this is?
6 weeks.
Oh, already 6 weeks. Okay.
He did great for 6 weeks. And now he comes in with symptoms from, or a stroke from the contralateral, the unoperated
Right.
carotid.
Yeah.
This is about, almost, we were about to book him for the second endarterectomy.
John?
Now,
So one point I would make is that, you know, I always would, prior to doing the second side in a person with bilateral stenosis, recheck either an ultrasound or a CTA or something, because you can see, you can, even in very rare circumstances, see asymptomatic ipsilateral occlusion at the site of your surgery. You can see the contralateral problems that you've demonstrated here. But this fellow, you know, really looks like he has sort of misery perfusion into that hemisphere. I definitely would want to do something to get a sense of just kind of perfusion, how much perfusion he has in the right hemisphere. Either do, you know, some kind of CT perfusion scan, or potentially do transcranial Dopplers, possibly with a CO2 challenge, see what kind of cerebrovascular reserve he has on that side. But to me, it looks like he really, you never see in any of these circumstances where he's really filling it out well. What did his, can you go back and show me the bifurcation there on the right side?
Yeah, on the right side, this is the now stump and the stenotic. He's got a high-grade external stenosis right here.
Yeah, so, you
John,
know,
to be the devil's advocate, does it matter? It does. He's stroked and his carotid has occluded freshly. Would those tests you want to order, would they change your mind what you might do?
yeah, so, you know, here he doesn't fill back to the skull base. It's been a few days. I don't think I would try to reopen the internal carotid. The question is, you know, whether or not, what you could do to try to improve perfusion in that hemisphere if perfusion is significantly impacted. I mean, if he just had it through an embolus when he had the stroke, when he occluded the carotid, but has great perfusion, then you might not think you need to do anything. But with that, with it looks like a lot of his perfusion coming through that external carotid, and it being such a tight stenosis, I mean, I think you'll likely need to do something to open up the external carotid, see if you can improve collaterals, but also so that you would have a reasonable flow through an STA if you ended up having to do a bypass on the patient.
So Bernard, I know if you showed this case to the Buffalo group, they would describe this as a potential pseudo-occlusion, and they would take the patient down to their angio suite and try and open it up.
Yeah.
And I think that if you, I don't know where Sadiq is, but I guarantee
He's here.
Oh, yeah, he would, I guarantee they would go inside. I've tried opening it up. I have yet to be successful. Maybe I'm not as good endovascular guys as those guys, but I think that, you know, in a fresh occlusion, and this guy is borderline, he needs something done. And this is a guy I would take down to angiogram and prove that he's not a pseudo occlusion and try and open him up and stent him.
So this is one I would take to the OR, and I think you have a very good chance of reopening that carotid, and it's a low risk procedure. And I just, again, looking through my database, we've done 127 complete occlusions. The group that we could initially reopen was about 60%, just a little more than that. A couple of them re-occluded, so the long-term keeping them open was 58%. But the important thing was, in that group, there were no perioperative strokes, because if you can't get it open, You know, you just do a formal, ligation of the internal carotid and an external endarterectomy and common to external angioplasty. But I think you'd have a very high likelihood of reopening this internal carotid if you took them to the OR.
So here's the issue, Jacques. I think the key issue here is what John mentioned, and that is, are the hits that the patient have simply embolic, or do they reflect a hypoperfused state? Because we don't have a vertebral injection. We don't know how good a flow this person has.
There is a vertebral.
Yeah, there's a bird.
The
Right here in the middle.
there it is, yes. So the question is, if you have an MRI which shows watershed infarcts, that completes my workup and would suggest that this guy is hypoperfused. Otherwise, you could do CT perfusion with them without Diamox. You could do TCD, breath holding index. Let's assume that the patient has no vascular compromise, does not have watershed infarcts, has good vascular reserve on the imaging. I would leave this patient alone, and that's the end of it, because the person had embolic terminal events, and while we might feel better opening it, however, if there is vascular compromise, you could open it a whole bunch of different ways. I agree with Gavin. If you look at the lateral, you can see the retrograde contrast from the external injection coming almost all the way back on the lateral view to the petrocervical junction, which means you could endovascularly reopen it. You could also reopen it the way Dr. Harbaugh is talking about, going to the OR and doing the Fogarty the way John showed it. Interestingly, one other option that I'm sure is what Bernard did here. Stent the ostium of the external.
So let me add, this is a fascinating discussion. Thank you, everyone. Let me add one detail that I left out purposefully. He was highly pressure dependent. So
there you go.
So here, we have to keep his pressure above 170. Anytime you drop below 170, even if you moved him off the bed, he would become symptomatic. So he was highly pressure dependent. And to Dr. Wilson's request, this is the MR perfusion, and I'm sorry I don't have the stroke MR, the diffusion hit, but it was a medium-sized stroke in the frontal lobe, and this was the mean transit time, and so he had significant hypoperfusion, and so at this point, Adnan, what do you think? Well, you just said everything.
Yeah, so from my standpoint, I think we would take him to angiography and see how big of retrograde flow he has. I like to open these with the MoMA system. MoMA allows you to do basically what you do with an endarterectomy, put a balloon in the external, put a balloon in the common, and then cross the lesion. If you are able to cross the lesion successfully, then we go ahead and plasty and stent and aspirate, and then confirm with an IVUS that everything is good before restoring anterograde flow. That's the best way to do it. If I'm unable to cross the lesion, if I'm unable to do it, then I would close this person and consider either an external stent, which would be needed if you want to do an STA-MCA bypass. Those are the ways I would approach it.
Yeah, sort of the things that are on my mind is his medium-sized stroke seen on MR, and I'm sorry I don't have it. I'm sorry for the overhead there. Sorry, give me 1 second here. Thank you. Sorry, that was a Mayo overhead about masks. Anyway, so my concern was the medium-sized stroke, and I debated whether to try to open the artery versus what you mentioned, Adnan, stent the external, and I chose to stent the external. This is him after, this is the external stented open, and very interesting, dramatic improvement in perfusion, and almost immediately came off pressors, essentially immediately, with dramatic improvement from this collateral to the hemisphere. My thought was, start with this, and then maybe down the road do an STA-MCA bypass if he still had needed more flow. Not saying this was the right approach, but just the approach I took in the heat of battle with this patient. He did well. I have this. This is
Bernard. Can I ask you why don't you think of this as a very delayed or an extreme diffuse or dawn patient with these delayed thrombectomies? You said it's 36 hours out.
Yeah.
I've seen papers out of Japan and so forth that they do
Yeah.
chronic occlusion.
This was from a couple years ago, and again, I'm just telling you what was going through my mind at the time. I think the diffusion perfusion mismatch would have been very legitimate to open the carotid. Again, I'm not saying this was the only way to do this. This is just how we did it. I think it would have been. I think what Dr. Harbaugh said, what Adnan said about opening the carotid would have also been a very acceptable option. So I don't dispute that at all. And I think Don, as to your point, Don reinforces that. I think that that notion, which this was before Don, but nonetheless, I think many of us were Don believers before Don came out. So, but this is just his fault. He did well, was discharged, doing well. This was the perfusion deficits here on the right were areas of infarct. So we normalized his perfusion. Never wound up needing a bypass, but I had that in mind as a delayed option. So anyway, not the only way to manage this, but just I like this case because I think it brings out some sort of issues about
great case.
Collateral and also EC to IC collateral, et cetera. So I thought it would be interesting to show.
Thanks, Bernard. Fantastic. Adnan, let's have you show your case.
Excellent.
I'll stop sharing here.
You have the best backgrounds there, Bernard, between...
Yeah, the Monet makes me happy during the day since I'm in...
Okay.
Excellent. All right, so here are my disclosures, none which are reflective of anything we did in this particular case. It's a 65-year-old who presents with an NIH stroke score of 6 from right-sided weakness and numbness. This is his original CAT scan. He has a pretty high aspects. I would say we would put him somewhere between 8 and 9. There's something going on out here, and there may be a small area of hemorrhage in the region, which is hypointense. We do a CTA head and neck. This is part of the original study that gets done within 10 minutes of presentation. And you can see there's a pretty high-grade stenosis in the distal left internal carotid artery. In addition, there appears to be a plaque close to the ostium of the left common carotid artery. And there is what's likely a tail of clot, which extends from that plaque at the left ostium. No clear large vessel occlusion is noted on the intracranial imaging. This is his CT perfusion. Again, this is the part of the study that is done when patients come in. And this suggests that there is a likely embolus in the distal paracentral postcentral MCA, M5, M6 branch, with a very subtle increase in time to peak throughout the left hemisphere. And here is an MRI. He doesn't get a thrombectomy or anything. He gets an MRI, and you can see multiple hits, probably a combination of embolic and potentially some watershed type distribution extending between the MCA and ACA as well, and a small hemorrhage in one of the regions with an infarct in the left temporal region. So summary, 65-year-old with an NIH of 6, scattered embolic infarcts, possibly some watershed hits on DWI, small temporal ICH, lesion with intraluminal thrombus at the left common carotid artery origin, and high-grade left ICA post-pulp stenosis. So I would love to hear from Dr. Harbaugh and Dr. Wilson, your thoughts?
Well, this is one where I think with those sort of tandem lesions, this is one where I think, having the endovascular option would be really very helpful. You can address both, various ways to do that. But this is one I would refer to one of my dual trained colleagues and ask them to consider endovascular to address both lesions at the same time.
I agree with that, but the thing that I'd be concerned about in this case is the thrombus at the proximal stenosis at the origin, and having to cross that to get up to the carotid bifurcation and to treat that proximal lesion, could create potentially some concern for distal embolus. I know there's been at least one case where we have taken a patient similar to this and done an endarterectomy, and retrograde went down and treated the proximal lesion, intraoperatively. And that, in that one circumstance, worked out very well. And I think that certainly I would talk to the two dual trained people we have here about that kind of possibility in this case, and see what they thought about it.
I think that's a good option, John. That makes a lot of sense.
I think that's an excellent option. Any other thoughts, Bernard, Gavin?
Well, but first of all, I'd get a good angio. The thing is, I think that this case is something that you don't have to cross the lesion. I'd at least get an arch aortogram, because you want to have as much information possible before you make a decision. So I'd want to, this guy must go to the angiogram suite, at least to get a diagnostic. Don't cross the lesion, as John says, but I'd want to have more information exactly what is going on.
Okay. All right, so this is what we did. We admitted the patient to the ICU, kept the blood pressure 130 to 150, and we heparinized the patient, keeping the PTT very tightly controlled between 60 and 80 with serial CT scans, because we thought this is somebody who would need to be heparinized, will need to be placed on aspirin and Plavix. We are concerned about that temporal hemorrhage that we had seen on the original CAT scan and MRI, and we're concerned that putting this somebody like this on dual antiplatelets and extending the hemorrhage might be an issue as well. So that was something really front and center in our mind. We made sure that the hemorrhage did not extend through a reversible agent. And then we did exactly what Gavin suggested. We did not catheterize any vessels because of the plaque. You can see here, there's some calcium right in that common origin, and a little delayed image shows what is clearly a glob of thrombus that's sitting in there. This is 3 days later on heparin, and you can see there's a little bit of a tail from the clot that's extending forward from the angiogram. So that's the angiogram. What would you do? And by the way, it shows the stenosis up in the internal higher up. We did not get any more selective imaging. So is that good enough for you, Gavin, to come up with a plan?
Unmute myself. Yeah, I mean, at least you know exactly what you have now, Adnan. So what I would do now is I'd really review how high is this, how much stenosis up in the neck?
The stenosis, let me go back. It's not that high. It's below the angle of the jaw. So I think it's probably C3, 4.
Yeah. But so I think I'll still treat this endovascularly. I think you can get past the stenosis, put your filter up distal to everything, treat the distal lesion first, and on the way back, treat the most proximal lesion. That's
Okay.
what I would do in this one.
All right. So that's total endovascular. We heard the hybrid procedure from John. Do an endart, go retrograde. Any other thoughts?
Ali, how would you handle the case? Is Ali there?
Yeah.
Oh, yeah.
Probably from an endovascular route, like Gavin was saying.
Okay.
All right. So this is what we did. We did a transcarotid TCAR type approach here. And I will sort of skip through the introduction here. And so we went to the patient. There is the incision we made at the sternocleidomastoid, open direct exposure of the common carotid artery, and put Rommel tourniquets above and below the exposure of the common, and then take the TCAR Silk Road system, which allows you to basically have a venous return for returning the blood and reversing flow, cross the lesion. And this is a pigtail catheter present at the level of the arch. There you can see the lesion. This is direct access. We can see the degree of stenosis. we have established degree of stenosis, we then go ahead and deliver the system. And once we have the system in place, we do our complete angiography to make sure we are good and make sure there's nothing else that is missing. Then create a roadmap, cross the lesion under flow reversal, do a plasty, then lay a stent out, and then confirm under flow reversal with IVUS that things are good. And once we have confirmed that, then what we do is we reverse the orientation of the sheath to point down. And again, we now do a reverse flow and see that's where the lesion is. And once we have that, then we just cross the lesion with, again, Rommel tourniquets are occluded. So this is complete flow arrest. So there's no concern that the thrombus is going to travel anywhere. And now we are using a covered stent. It's balloon mounted, and put it across the lesion and inflate it into place, and then withdraw the system, flush out, aspire whatever clot might have released before we release the tourniquets, and then do a pigtail run to confirm that there's complete patency, and then close the lesion. The patient actually ended up doing very well. Sorry about the font weirdness. MRS of 2, NIH of 2 at 3 months, and was discharged to rehab and did very well. So that's what we ended up doing in this case. Again,
That
different
was
ways.
really clever use of the TCAR system. That was great.
So, I mean, I think your approach is exactly what we would have done in the past. And that's how we used to do before the TCAR became a system.
I'm only 1 year older than you, okay? I'm not, probably.
Say that again?
Probably 1 year older than you, but I agree. TCARs, I mean, Alan Lumsden does the TCARs, yeah. I haven't done them, but we'll start doing them together. I mean, that's a great idea. I didn't think of that, but that is a more modern idea. Alan Lumsden's done about, I think 10 or 12 already.
Yeah, we were part of that original trial. We did about 18, 20 of those on that original Roadster trial. And the fact is that if you look at the actual data, again, it's not randomized. Their stroke and death rate was 1.4% in that cohort of 130 or some odd patients, all again considered high risk.
And Adnan, that is exactly, I know the ones that were done, yeah, were selected to be extreme high risk.
Oh, yes.
So that's good results.
So those are very good results, right? But I think that's the value, again, the value of being able to do it one way or the other and combining, and, the right hand and the left hand working together to come up with novel solutions. I think that's the best part of neurosurgeons doing this endovascular strategy and coming up with the safest possible way and individualizing care.
But Bobby Stark, can I invite you to comment on this case in general, TCAR and tandem lesions? What are your thoughts?
Yeah, beautiful case and a nice outcome, Dr. Siddiqui. I was kind of thinking the same thing. I think this is a nice case for the hybrid suite. You could even consider doing an endarterectomy, and then you've got clamps on the internal, and then you can go down the common and drop a stent is probably the easiest thing for that distal common clot stenosis. So then you'd have distal control. You're not going to get any clot, but I think the TCAR is another nice way. I think that, we're probably having some improvements in carotid endarterectomy over time, but we are definitely having a lot of improvements in carotid stenting over time. I think, University of Miami, we favor endarterectomy for a vast majority of patients, but still, radial approaches, TCAR, and MoMA are probably three of the things that, and advances in better catheters are probably the three things that are really improving our endovascular outcomes as well.
I completely agree with all those sentiments. In fact, I would sort of talk about this data that Bob talked about from that combination study. I think it was the ICSS follow-up looking at DWI hits. And if you look at the stenting arm, you still had hits on DWI that theoretically should be all gone like 30 days later. And part of the reason you have them is that all the stents have these massive tines that are open, and you're plastiking it, and there's this cheese grating effect which continues well beyond the stenting. So there is the acute stroke that occurs when you're doing the procedure, but then post-procedure, there's some data to suggest up to half the embolic events occur 24 hours and beyond stenting. And so with new stents that are out there, like the Casper, or the mesh-covered stents that are available in Europe now, I think might really make a significant sort of progress in terms of making stenting a little bit more safer in terms of cheese grating. So I agree with you, lots of innovation happening. Eventually, endarterectomy is going to become a minority of procedures.
I don't know about that. It stood the test of time, as you know, for a few decades. And to be honest, it's beautiful what you've just done, but really quite complicated, isn't it, technologically?
It is, but I think if you control the hybrid suite, if you're there one way or the other, it is quite seamless. For instance, I do about 30 or 40 endarterectomies a year on a regular basis and 40 or 50 stenting. So it works seamlessly. And then you try to figure out novel ways. Okay, what's the lowest risk for each one? I love that. I could see where Bernard was going with that. The moment I saw that external ostium stenosis and I saw the rich collateral, I knew where his head would go. So it's the beauty of being able to have that mindset, I think, that allows you to bring those things in play and come up with novel solutions.
Beautiful. Thank you, Adnan. Ali, may I invite you to share your case?
Of course. Dr. Morkos, my mentor and my older brother, thank you so much for your kind invitation. I just want to sort of echo what Adnan is saying. You know, neurosurgeons are competitive people by nature, and we're sort of always pinning one thing against another, whether it's aneurysms, clipping versus coiling, or stenting versus CEA, and we're doing it not in a malicious way, but just to kind of do things that are the best for our patients. But I think as we're starting to learn, these things can be complementary, and it can be tailored for patient and a situation. So I just like to present this case that I had. Let's see. So 71-year-old male with a previous history of stroke, but made a very, very, very good recovery. AFib, Eliquis, hypertension, hypolipidemia, a vascular path, and comes in with dysarthria and mild weakness. Has a few new hits on the right side. Can you see my screen?
Yeah, we see your screen.
Sorry, it froze up on me for a second. And so there's this right carotid stenosis, greater than 70% of thrombus on there. We, just for time's sake, I'll take you guys through it for a little bit more and then ask what would you do. So we decided to do an endarterectomy on this gentleman. The endarterectomy, 20-25 minutes cross clamp time, no SSEP changes or EEG changes. It was an uncomplicated. Maybe I should have been, I've thought of this case, and I thought maybe, like Dr. Wilson was saying, be very meticulous with that distal cleaning. I also remember sort of Harrows, which I didn't do in this case, sort of telling me to put tack-up stitches at the end. Anyway, we closed up, everything was okay, he woke up okay. Within an hour, he became plegic on the left side, and had this CTA, if you will. So
hold on, Ali, may I interrupt you, because this is like an interesting point to ask the panelists. Patient, anybody could answer this. Patient wakes up plegic 1 hour later. What do you do? Do you do a repeat study? Anybody goes straight back to the OR, not to waste time? John or Bob?
I'd prepare the OR, but I run them through the CTA scan on the way. I think the information that you get versus the amount of time it takes, it's worth it. You know, back in the days when we would have to get them to the angio suite to get a decent study, or, you know, try to get an MRA or MRI or something, you know, it just wouldn't be worth it. And I would have taken them straight back to the OR. But now with the ready availability of CTA and it not taking more than, you know, 5-10 minutes on the way to the OR, I would definitely do the CTA.
Yeah, I agree. I think the era of rushing people back to the operating room is gone. I mean, for one thing, if you cross-clamp this guy and there was no ischemic change, why do you think an occlusion now in the neck would be the problem? I mean, if you can't see the distal vessels, you're missing the real problem. So I think the CTA makes sense, and then you have a better idea of exactly what you're dealing with. We actually looked at this issue a few years ago, and it's a distinct minority of patients who present with, you know, post-operative symptoms like this that have a internal carotid occlusion. So you'd be taking an awful lot of patients back to the operating room, delaying definitive treatment and not accomplishing anything because the carotid in the neck would be open. So I think this is the way to go.
Okay, so now we go back to the panelists. Would everybody go back to the OR? Would somebody go to the angiography suite?
So
what would you?
One other thing to keep in mind is that it's rare, but you also have to deal with the prospect of a hyperperfusion syndrome and a hemorrhage. So I think going to the CT scanner absolutely makes a lot of sense. And because of exactly what Bob said, you know, you just cross clamp this thing. So you know you got something which is distal. And if you go to the OR, unless you've got a hybrid suite, which I think, again, one of the key messages is that we need to control the hybrid suite better. And neurosurgeons lose out to the vascular surgeons, and that is a mistake. I think we really should routinely do these procedures in the hybrid suite so you can look distally, because the problem here is beyond PCOM. And you know, for that, you need to bring in some endovascular tools. So I think going back to the OR is the standard old mantra, but just doesn't hold water in the current day and age.
So Dr. Wilson, Dr. Harbaugh, you were talking about your series. I think Dr. Harbaugh had 0.2% with an embolism. What is, I know it happens rarely, but when it happens, how do you reperfuse, and what are the rates of reopening this with a Fogarty balloon?
Well, I think that there's, in an acute occlusion like this, I think that there's a high likelihood of being able to reopen this. And I think one of the key points that I would make is before you start passing Fogarty's or anything, I get into the OR, open up the endarterectomy site, and, you know, don't have the internal cross clamped at all. A lot of times the clot or the platelet aggregate or whatever it is will deliver itself. But if it doesn't, you know, then going through things like Valsalva maneuver, having the patient cough, oftentimes that will, you know, increasing the venous pressure intracranially and in the cavernous sinus will help deliver things out. Because I think the less you have to instrument the distal internal carotid, the more likely it is that it's going to stay open long term. So I always try to do that first, and then would pass a Fogarty if I was unable to get it open otherwise.
So what could you tell about the intracranial vessels on your CT angio?
Dr. Harbaugh, didn't look very good. It wasn't, I couldn't tell how high it extended. The intracranial vessels seemed open, but I couldn't tell how high this extended. It came in and out. So I thought maybe there were multiple areas of clot, but intracranially it was okay, but he was hemiplegic from this.
So I don't know. I'm perplexed by this because, you know, why should the internal occlusion, if there's not any distal embolization, be a problem now when it wasn't a problem intraoperatively? And
Intraoperatively, I pushed their blood pressure up and so forth. Maybe that had to do with it. It was under general anesthesia, so there were signals, but they weren't changed.
okay. Well, I mean, I agree with John. I think that, if you don't see anything intracranially, the only reason you have for the deficit is this internal occlusion in the neck. The likelihood of being able to get that open again is very high. You can address any technical issues that might have been missed at the first operation. And Dr. Wilson is exactly right. Usually in this setting, when you open that vessel, you don't have a clamp on the internal. You'll often see a spontaneous delivery of the clot back into the endarterectomy site. So I would approach this the way John said under those circumstances.
Right. Well, you see what we ended up doing, but anybody else, Gavin, Bernard?
Well, Ali, I would not. First of all, I agree with them. And the reason being, I'd get a CT. I wouldn't even go to angio suite because the problem is you don't want to put a stent in a fresh clot. I would have made sure there's no hemorrhage and to get a CTA of the next strata. I wouldn't take the angio. I know you can get a dyna CT in the angio, but I would have done exactly that. I would not have taken the angio. I would have got CT head to make sure there's not, I wouldn't have got a CT head, just got a CT to make sure there's no hemorrhage. Patient straight down to the OR, reopen up. I think going to angio, is easier these days, and I'll show you about my case. I mean, why I do a lot more angios than a lot of the other guys do, but I think it helps you. But in this case, I would have went straight back to the OR after a CT head to rod hemorrhage and a CTA, but take him straight back.
My personal vote would be I like the CTA head and neck because if it's an M2 occlusion or M1 occlusion, you want to know that because the approach would be different. That's.
I would say, Ellie, I would take them to the angio suite because I believe that even though your CTA might not have been very clear, and many times as motion artifact, people are moving, you don't get good enough images. This is not a proximal carotid. You just did the case, and yes, you didn't have signals. There is no, you just don't need to plasty a fresh endarterectomy. You can just lay a stent and it'll open it up. There's no plaque anymore, and then just aspirate your way up top. I think it can be done safely, effectively, and most importantly, allows you to exclude those distal emboli, which probably are there. I think it's not, you can do everything you can do in the operating room and you can go intracranially. Again, ideally, this would be a hybrid suite where you do exactly what you're talking about, reopen. And if that does the trick, then you can do an angiogram at the same time. Unfortunately, we don't do that, which is a mistake.
Yeah. So that's exactly my point. So as Dr. Harbaugh showed, we have to get our complication rates lower and lower and lower. In symptomatic patients, it's no longer acceptable to do it at 6%. It's got to be down to 3%. Is the future of this, especially as more and more vasculars or surgeons are training in hybrid sort of environments, to do all of these cases angio ready. And if there are that 0.2%, as in Dr. Harbaugh showed, chance of an embolus or something, you're there to catch it, and you decrease the overall risk of the procedure. I don't know if what I did was the correct way of doing it, and this is a hybrid room, and we were prepared to do both. But this is how I started and how I ended up. And I don't know if stenting is correct in this situation, but that's what we did. So I'll do it for a 30-second video. So this is
Ali, did you have proximal control? Did you have a balloon in the neck?
I'm sorry, say that again.
In terms of distal protection, how did you manage? What was your strategy for distal?
This was a suction catheter. You see this catheter here. This is one of the big suction.
Ali, can you put a better view? Like the screen is small. Is that the best way you can show it?
No, I can show it bigger.
Yeah, if you can just full screen it, I think that'll help.
Yeah, better.
Just a couple of points, and it's to illustrate that there is a fusion of an adjunctive instead of competitive. So this is a suction catheter, Bernard, as you know, and then this is the microcatheter. I'll just play it fast. We were able to get through the clot, and we then deployed, and so it was open distally, as you can see. but from the point of where the big catheter is here to the top, it was clotted off into the sort of skull base. And maybe a Fogarty was enough to back bleed that. This is a stent retriever with all of these little dots. This is a suction catheter. And this is us pulling that back. It opened the vessel as we were suctioning and pulling back. But if you look at here, it's what Dr. Wilson said. I don't think I either overstitched it or left here. I left something there, either plaque not cleaned out enough or not properly stitched, but there was a stenosis and it was impeding flow. So we loaded the patient with Plavix and ended up stenting. Intracranially, everything was open. The vessel opened up. This is a delayed MRI. He did have new stroke burden from this, and he was hurt as a consequence of these complications.
This is a good job, but the thing about, and that's the one thing that concerned about me, when I done, I was agreeing with you. When you're gonna go do this, I'd be worried that you're gonna push distal clot distal. And I know that, I know you use a suction catheter and all that, but I do think you're gonna find some clots, even that you're not gonna have an M2 occlusion maybe, but you're gonna have some distal vessels, and that guy's gonna be showered with clots. So that's why, even though I do endovascular, 20% of my practice, I would still, this one, take to the OR.
Well, again, just to counter that, I would do this with the MoMA type device. And I think that's what I think Bernard was talking about as well, is you don't need a distal. I would do exactly what you did, but if you had flow arrest proximally in the common,
Sure.
You could have addressed the carotid and probably not induced. I mean, there might have been embolic events already taken place before you ever got there. That's possible. But I think every time we do these, there's a risk of distal shower. And that's the advantage of doing what John and Bob are talking about with doing an endarterectomy, is because you have complete flow reversal. You can do the Fogarty, and in this case, that would have resolved the problem. But if you're going to do endovascular, I think we need proximal control.
Thank you.
Carl actually may be a good one for this case as well. You know that?
Say that again?
What do you think about a T-car for this case, Rick? If you had to do it again, because then you're going to get real proximal flow control.
Well, I like Ali's idea of doing this in the hybrid suite. You need to put an A-line in these patients, just put a femoral or a radial so you have your access. And then you have all the salvage you need. At the end of the procedure, just take the A-line out if there was no problem. And if there is, you have access. I think we need to take make a stake in the hybrid suite. I think that's really important for dual guys.
Agreed.
I gotta say, as far as T-car is concerned for this though, it doesn't make sense to me to make another incision in the carotid more proximal. If you're gonna cut down the carotid anyhow, just take the staples out or the stitches, and your endarterectomy site is right there. You're open in 2 seconds.
Dr. Wilson, there's balloons. This is how we do thrombectomies. You're right. You can just inflate a proximal balloon and you have flow arrest, and then you have a suction catheter, and it's
right.
Hey, Jacques, could I share my screen for a second?
Sure.
Promise I won't take up too much time, but we looked at 36 patients out of the whole series with an early postoperative event. 22 turned out to be ischemic strokes, 12 were TIAs, and then there were 2 hemorrhages. And what we asked are, what were the risks and benefits of these various diagnostic and treatment approaches? Primarily, do you image or do you go right back to the operating room? 2 of the patients had intracerebral hemorrhage, which was diagnosed on CT. I won't talk anymore about that. They both ended up with Rankin 3 strokes. Of the 34 patients who had postoperative ischemia, we found there were cranial CT findings in the 34 patients, and there were no new lesions seen on the intracranial plane CT scan. But if we did either angiography or CT angiography, 23, we couldn't find any pathology, neck or intracranial, and those resolved. There were 4 internal carotid artery occlusions, so those 4 would have benefited potentially from going right back to the operating room, but that's 4 out of 34. There were 2 additional patients who had technical errors, an intimal flap and distal stenosis, so those 2 potentially could have benefited from going back. But that's still a very distinct minority of these patients who would benefit from a trip back to the operating room without imaging the vessels. And I think the other point is that if you have distal embolization and the carotid looks okay in the neck, which was the majority of the case, now you have an option of going in for clot retrieval and not wasting the time going back to the operating room and reopening the neck.
You make a very good point, Bob. You're right.
Thank you.
If you could stop sharing, and then I'll ask Gavin to share his case.
Sorry.
Okay, so mine's gonna be a little pretty simple. Can you see my cases?
We only see your name.
You don't see it? Okay, see that?
No. Remember, like you did earlier, the share
Oh,
screen.
yeah, we were sharing. Hold on. Hold on. Okay, you see it now?
Yes.
Okay, good. So I'm going to give you basically a lot more simple. Adnan, used the methods, don't have too many complications. So this is not a complication, unlike the Buffalo guys. Anyway, this is a 57-year-old female.
Sorry, can you click on play it, not the navigation mode?
Okay.
Play, yeah. Play the one slide. Yeah, here you go.
Okay. Right.
Yeah.
So this is a 57-year-old female, past medical history of long-standing type 2 diabetes, hypertension, a smoker, but stopped 15 years ago. Presented with 4 episodes of left arm weakness over a period of 24 hours. CT and MRI were both negative for strokes, and she had an echo workup as well, which was normal. She saw a neurologist that got the CTA, both head and neck. And as you can see, she's got a smooth narrowing of her right ICA just above the bifurcation. Left side, I'm not showing, was normal. So any other imaging that you guys would do, John, Jock, Bob? Hello?
Yeah. John, any other imaging besides what we have before you make your decision?
No, so it sounds like she's had a right hemisphere TIA. She has a right carotid, internal carotid stenosis. Not, unless I'm missing something, I think based on what I've seen so far, I probably would have taken her to the OR. I suspect that that's going to be the wrong answer.
No, it's not.
Presentation, but that's what I would do in all honesty.
I agree on all points, and I'm waiting for the next shoe to drop.
Yeah, so the thing about it is that I brought this image up because I think that a lot of John and Bob, in the old data, angiography was not done often for these guys. People thought that it's really dangerous, but I find, as I'll show you now, it's helpful for me. So I do angiograms, okay? And this is one, we did the angiogram, which clearly shows the stenosis. I also do the intracranial run, obviously a common run that shows one. This image, which looks like there's, an atretic right A1. And the reason I do this is I'll tell you a little later. But anyway, if you did angio, you only could, would you only do the symptomatic side, or would you guys do both, all 4 vessels or 6 vessels? Adnan?
4 vessels, or at least 3. I would do a common on the other side and avert to look at collaterals, because that could be a washout and just reflective of very high grade cervical stenosis.
So John, in your practice, and Bob, do you guys get angios, or were you taking this patient straight to the OR?
Straight to the OR.
Adnan?
Yeah, OR.
Angio,
Not angio.
always angio.
Yeah, me as well. And I'll show you, I'll show you why. And I'm going to see, so this is the angio. So unlike, as Anand said, the left ICA shows great crossfill, plus she's got a PCOM. And the reason I do this is that I use this information. I look at the, how high the carotid bifurcation is, and also want to really look at the disease. The CTA is pretty good these days, but it doesn't give you as much information as plaque dissection, unstable, and most importantly, I look at the collateral circulation. And I think with carotid disease, and getting back to what Bob said, our risks and our complications have to be so low. So for me these days, to do an endarterectomy, everything has to be optimal. If it's not optimal, those patients go for a stent. And I personally think, I used to shunt patients, but now if I can predict, and it's not an absolute prediction, but if I can say this patient is most likely going to need a shunt, I'm going to send the patient to, I'm going to stent the patient. In this situation, if I got the CTA, I would have probably thought, well, she may have needed a shunt, but getting the angio, like Adnan shows me this patient's got a great collateral circulation. I can go inside there, do the case, and no one won't need a shunt and get her in and out. She's young, she's female, she's an ideal candidate for a CEA. The other question I'll bring up about, do you guys do patches? And I know, this is an easy case, much like John said, I only patch if needed. And that's the, 2 years follow-up of an angiogram. And the overall theme of my talk is basically not complications, is that I try and keep my endarterectomies very simple. Due to the methods, I have a lot of competition. I have to have almost zero complications. And the way to do that is to make it very, very simple. So anything complicated, bilateral stenosis gets stented. No collateral flow gets stented. Some of that I'm gonna, any complications, they get stented. The ones I do endarterectomy these days is someone that has got a perfect case for endarterectomy. Otherwise, I stent them. That's all I got. I don't have much complications here.
Thanks, Gavin.
The angio has to have some complication.
It does, but it's so small. Hold on, I'm trying to get you. The thing about it is that if you look at most of us these days that do a lot of angios, let me try and join you guys again. It is so low. And I think that, I think the Columbia group looked at their angio complication rates and it was minuscule about 10 years ago. And I think if you look at the complication rates these days, it is even less. So for me, the whole thing about this talk is I try to do endarterectomy, keep it very simple. And if it's not simple, I stent them.
I think CTAs are really useful for evaluating primary anatomy. Now, why do we do a diagnostic angiogram? I'd be honest, sometimes I wonder why. I think it's just a matter of traditional workup that we engage in. In many cases, I think CTA gives you a lot of information, but every now and then you miss things. The resolution of CTAs is excellent for carotid evaluation. It's really in the eye of the neuroradiologist when it comes to intracranial circulation. And we routinely will miss things like small fistulae, small aneurysms, others. And so while that might not be necessarily germane to the carotid lesion that you are treating or not treating, we routinely do diagnostic angiograms, and our complication rates, unfortunately, we are still in August, are higher in the first quarter than the last quarter of the year. So I think there is a risk to it, and I sometimes do wonder if we really need it, but we do it.
Okay, I'm sorry, I just want to have time to go over the questions from the audience, if that's okay. Gavin, you're unable to unshare your screen. Otherwise, let me ask some questions. Bobby or Carolina, if you want to also look with me, if you see a particularly good question, you want to pause it, jump in. I'll just start with the, can I ask just the first one? And maybe we have time for one answer unless somebody strongly disagrees. Can anybody comment on the cost difference between CEA and stenting, let's say at a 1-year follow-up? Anybody wants to tackle the cost issue? This is from
sure.
Dr.
There's a lot of data, published data, that indicates that there's significant cost savings from carotid endarterectomy as opposed to carotid stenting.
Yeah, and one of the things we found too is that one of the reasons I switched from general anesthesia to regional anesthesia, it used to piss me off to find out that the neurologist who was reviewing the EEG the day after the operation got paid more than I did for doing the surgery. So, regional anesthesia is very cost effective too.
Exactly. Yeah,
Everything
that's
we
what I
do
meant,
adds to the
the
cost.
cost of regional endarterectomy and a regional anesthesia, as opposed to general or stenting.
Yeah.
So Jacques,
Question. Oh, sorry. Go ahead. No, I was
I was just
answering.
going to say you were muted.
Yeah, no, sorry, I was answering a phone call. A question from Dr. Mohammed Al-Fiki. Is there an age difference that may affect your final conclusions about stenting versus endarterectomy? Anybody wants to tackle the age issue?
Well,
I think that,
go ahead. Someone else can take it.
go ahead, Dr. Harbaugh. That was well covered, I thought, in your slides.
Yeah.
Yeah, I mean, I think that initially it was thought that advanced age would be make it a dangerous carotid, so they should be stented. It turns out that age does not seem to affect the risk of endarterectomy. There just doesn't seem to be an effect there. The older patients do seem to do worse with endovascular treatment, and since I don't do that, you can, I'll defer to somebody else as to why that might be the case, but I think there really is an age effect with older patients benefiting from open surgery more than endovascular.
We came up with this thing called the Buffalo Risk Assessment Score, called the BRASS score, and that really quantifies this risk. And while it's related to age, it's not dependent on age. It's got to do with tortuosity. Endovascular procedures are easier in straighter vessels. And if you got a tough arch, I think it's complicated. I think radial starting to make a dent in that tough arch concept because of transradial approach. But on the whole, I think you need to evaluate the anatomy. You look at the plaque. You look at collateral circulation. I think that makes a big difference. For instance, again, we were talking about asymptomatic disease, and Dr. Harbaugh is really looking forward to Crest II providing that, shining light. I'm a bit nervous about how people are enrolling, even though they have like 1,800 patients in that trial. I think there's a lot of selection bias in there. I say that as a site that is enrolling. I look at collateral circulation or perfusion scans in all my patients, and I really think if somebody's got high degree of collateralization, age is irrelevant. On the other hand, if they have a really isolated hemisphere, asymptomatic or not, again, age is irrelevant.
And then I agree with you. I think the biggest thing, I always tell my residents, when you go to war, you want to have as much information available before you go there. And evaluating the collateral circulation as a vascular surgeon is extremely important, regardless of what you do. And that's why an angiogram is really good.
Along the lines, you were mentioning that to analyze the type of the plaque and a little bit of the anatomy of the plaque, one of the audience members wanted to know whether or not you utilize advanced MR sequences in the preoperative imaging to identify features of like a vulnerable plaque.
We've done that for research, but not for making clinical decisions.
Is that the vessel wall imaging?
Yes.
Yeah.
There are two types. There's the black blood image sequence, which works better for cervical coils, which is really, again, it goes in the same category as doing pre-procedure transcranial Dopplers looking for microemboli or black blood showing plaque, and then vessel wall imaging. Again, I agree with Gavin. I'm a hoarder when it comes to information, and I think the more information you have, the better it is. So we routinely do that for asymptomatic patients.
Okay. One of the audience members asked, what do you think about carotid endarterectomy or ICA stenting for acute stroke? Can you speak a little bit to the timing?
Any of you?
I'll speak to
Go ahead.
endarterectomy. the NACID trial indicated that it was safe to perform endarterectomy in patients with acute stroke, acute non-disabling stroke. And so, you know, if a person still has territory at risk, then we will perform an endarterectomy, you know, as soon as they are in the hospital. If they've already had a hemorrhagic conversion, or if there's really, you know, no additional territory at risk, the completed infarct, then, you know, that we may not proceed urgently. But otherwise, we do them all same day or the next day.
Yeah, I agree.
You know, there are two categories there. One is the symptomatic patient who comes in with a stroke. And that's the one that I think John and Bob are talking about. The other is NIH 10 plus who comes in with an acute carotid occlusion with a tandem occlusion, what to do about these. I think even though these patients have been uniformly excluded from the prospective trials, one needs to recognize that that's about 20% of large vessel occlusions have tandem occlusions, 20%. The best way to deal with them is to go ahead, cross the lesion, open the intracranial. Personally, I think the better way to do this is to stent them at the same time. I tend to stent them first and then go ahead, deal with the intracranial. And based on Mr. Clean, which was the only trial that allowed those patients, there was tremendous benefit to reopening these acute occlusions.
But it really depends on the size of the stroke. If you've got a moderate sized stroke and you're going to start antiplatelet therapy dual, your hemorrhage risk is going to be much higher. So in those situations, you can do the thrombectomy and do angioplasty. But I actually, and we have data here which we must publish. If you have a moderate sized stroke and you start that antiplatelet therapy dual, you're going to have a hemorrhage risk.
I agree with you, but I think the deficit from non-revascularization far exceeds the hemorrhagic.
I agree, but I think in those situations, do an angioplasty and then come back.
Sure.
I've been selective. Most of the time I've done what Adnan said. I put a stent in at the same time, but there are cases, if I'm nervous, I had a case recently where a patient was very far out and I just did an angioplasty and I'm bringing him back for a stent. So that's another way to do it.
You know, despite reopening, you sometimes don't know the overall stroke burden. So our strategy is if you can angioplasty and it stays open, leave it like that, check it in a few days, and then come back and stent. We looked at our patients in Miami actually before we left. 26 patients. They actually did better when they had these tandem occlusions, whether that carotid stenosis over years built up good collaterals. They did better in acute stroke when they had tandem occlusions.
Bob, about using patch, do you ever use patch? You don't do too many recurrent endarterectomies. That used to be the old indication.
Yeah. So early on, when I was doing, people who'd had previous surgery, I would always patch the recurrent ones. If there was somebody who had a particularly small vessel, I would occasionally use a patch in a new endarterectomy. I haven't used a patch for years because the recurrent stenosis now I think is best treated endovascularly, and keeping the operation simple and just doing a meticulous primary closure I think is the best way to go.
Ali, how is it possible to treat a delayed stent occlusion?
We've had a few. Usually when people take off prematurely from dual antiplatelets, which should be on for 6 weeks or so, but I think it goes along the same sort of video that I just showed. You are able to recanalize them, use the same techniques that you use for a thrombectomy. So it's the same sort of concept. Go suck it out, stent retrieve it. Sometimes you need to give ReoPro or Integralin, something like that. But the point is how soon you can catch it from its thrombosis.
This is anybody from the panel. Would using intravascular ultrasound change your decision making in asymptomatic patients?
So I routinely use intravascular ultrasounds in 100% of my carotid stent cases. And it's not about trying to see what the plaque looks like before I do the case. I always use the IVUS after the stent, right before I remove the filter, to make sure I haven't cheese grated something that I might not see on angiography. And I can tell you it helps me 1 in 50 cases. That is about the rate of asymptomatic of symptomatic stroke. So I'm a strong believer. Again, it's about minimizing risk in all these cases.
Yeah, but don't you think I mean, the intent of the question, I guess, is can we identify a subgroup of higher risk asymptomatic cases?
I do that preoperatively. The Doppler ultrasound gives you beautiful information about what the plaque looks like. I mean, it is underutilized. I run the Doppler lab here at our vascular institute, and I mean, all the information you really need is there if you add that with the plaque morphology.
Okay. John, what suture material do you use for your endarterectomy?
Use 60 Pronova. It's a Prolene-like suture, monofilament. Seems to have less memory than Prolene. That's what I.
Bob, same thing or
Same.
what? Same?
Used to use Prolene, but it's a little stiff.
Do you use Ethylon?
Yep.
Okay. Does anybody, can we answer Dr. Pablo Rubino, what is an absolute indication for stenting in case you have it? Anybody would like to say, that's it, the endarterectomy makes no sense, stenting is the way to go?
Symptomatic.
If you have a payment that's due on your Lamborghini, then you must do the stent if you're an endovascular specialist. But beyond that, I'm not sure. I'll let Bob answer.
Yeah, if symptomatic recurrent stenosis, I mean, I think somebody who's had a previous endarterectomy, that operation, even if the stroke risk isn't dramatically higher, the risk of cranial nerve injury is significantly higher. It's no fun to do that operation, and that's one that I would always send to the endovascular specialist.
Well, and the last question was already answered, and it is 7:28. I'll give you any last minute question, comment, anybody, before I let you all go.
I just want to thank you for putting this together, Jacques. This was a great symposium. They all have been great. Really been doing a great job. It was a lot of fun. Appreciate you asking me to participate.
Same here.
I echo that.
Thank you.
Great
Thank
work.
you to the participants, panelists, my co-directors, speakers. Have a good evening if you're on the East Coast.
Thank you.
Bye.
Thank you.
Bye.